Thank you very much, and good morning, everyone, and welcome. And thank you very much for the nice introduction and a little bit of a summary of who I am. Perhaps a little bit about my background. I'm based in Germany, teaching at a university, and we had the privilege, as part of the university, to work with the World Health Organization to develop a book that will be coming out in January on integrating the social determinants of health into health workforce education. So this theme is being taken up by the WHO. There was a report last year by the UN saying that the social determinants should be the focus of health workforce education. So an extremely opportune moment to begin to start talking about this theme. And as mentioned, I had to work with a number of people in the room today on the Academies model and framework for integrating the social determinants of health into health workforce education. So what I'd like to do is very short, 8 to 10 minutes, to take some of Ruth's concepts, and also Carl mentioned about having some learning contract, and that will lead into the table discussion. So really very briefly, but really what you really need to do is get down and to start talking about putting this into action. So again, as Ruth said, if you look at the model, on the left-hand side, you've got the structural determinants, as you mentioned, money, power, resources, and those policy choices. So that's on the left there. In the center, that's the second half of the definition of social determinants. That's the conditions that are around us, that we live, that we're born into, that we grow and work in. So that's how we looked at those two things. And what that enables us to do is to really start to measure and understand the social determinants in a sort of a logical and structured way. And as we go on through the workshops, we're going to be looking at some case studies or case histories. And those tend to focus on, and I think a number of people have mentioned it this morning, health outcomes. And when we look at health outcomes, it's very time-bound. It's often at the end of treatment. But actually, when you start speaking to the patients, they talk about the consequences. It's like before and after. What happened to me? What am I living with every day? Loss of employment, difficulty in transport, difficulty in looking after my children. Actually, I'm not as healthy as I could be. I'm having difficulty in recovering. And what you can see at the top there are the feedback mechanisms and pathways. And Sandy and I think Neil mentioned that it's those mechanisms and pathways, the complexity around what we're trying to deal with. And I think the last lady also mentioned that. Very easy to sort of compartmentalize it into a medical problem, but it's actually what people have problems with, is everything around it in their daily lives that just make things so frustrating for us as health workers in treating those people. And I think that then leads into this idea, and it's been mentioned by many people this morning, about living histories. I mean, Ruth mentioned as well, where does one thing stop and and another thing begin? The genetics, the history, the family history. So we now need to looking at living histories, that it's not a static outcome. It's more of an ongoing process. And we need to see that in that respect. The other thing is in terms of the social determinants, and as Ruth said, we're all affected by the social determinants, all of us. But the big differential is where we are on a social gradient. Some people are more affected and a little bit lower down on the social gradient. You can see if you're not in poverty, you've got good education, you've got a good job, you live in a nice area, exactly as Ruth was saying, that slope is actually very, very shallow, and you can push the stone relatively easily. If you're living in poverty, you've got limited access and had limited access to education, you're living in very challenging housing conditions, you're living in a food effort, that stone is almost crushing you. It's going to be virtually impossible to move it. So when as a health provider you say, can you do a little bit more exercise or you can change your diet, the person is just crushed by life generally. And that's what it is, by life. The social determinants are effectively what most people outside this room, when you ask the public, that social determinants life. That's what's crushing me. And that's what we need to start understanding. And for those of you perhaps remember, that's the Pink Floyd cover. And again, Ruth's comment this morning, it's about those policy choices. As it travels through that prism of you or where you are in society, it gives you all those options. How many resources do I have to call upon? And that, I think, is what one of the table exercises is digesting what Ruth has said and actually reflecting, where do I lie on that social determinant gradient? Because it's my point of view and my viewing place in that gradient has an effect on how I start understanding the person and their their situation on the other side of me. So one of the things in the table exercise is actually to review your own social determinants. Where are you? Because they affect you before we start talking about other people's social determinants. So those are the two things particularly we'd like to discuss. And the other thing is, when we're talking about addressing the social determinants, it's also proportional universalism, as Michael Marmot said. It's like we wanted to see the social determinants as a holistic exercise, because it's policy, it's conditions, but put focus and intensity where it's needed, the people who really, really need it. So it's not we're just going to concentrate on them. We're doing everyone, but we're just focusing on those that really are vulnerable and need that extra support and help. And I think, very interestingly, I teach social determinants in Germany and in Europe, and can really, the comments coming from today really resonate, because is it sufficient to treat people's illnesses without treating and addressing the situation that made them sick in the first place, and we're also returning the person back to? And obviously, if you look at that, you then next question, and I think that was almost the last question, is it sufficient to educate and train health workers to treat people's illnesses without educating and training them to change those circumstances that made people sick in the first place? And as Ruth said, we tend to concentrate on that 10 or 15% on healthcare outcomes, but the other 80%, that's got nothing to do with medicine, that's got nothing to do with dentistry. You know what? That's someone else's job. And when we come to talk about integrating, the problem is it's often, social determinants. Oh, yes, we'll just do a quick module and just tag it on somewhere. We need to mainstream social determinants in all curricula. This needs to be, if it's 80% and it's only 10% health outcomes, that needs to be mainstreamed. So that is a key point today when we're thinking about, as Carl said, what's our learning contract? We need to start talking about mainstreaming the social determinants. And then moving to the framework of the Academies framework, we put lifelong learning in the middle. And lifelong learning isn't synonymous with continuing professional development. There's a huge amount of work going on in the education sector, and it is really looking at lifelong learning at the policy level as well as the institutional level. So it's a completely different concept to, it's really looking at life and learning and bringing everything together. And in terms of lifelong learning, that will help us mainstream, because we start looking at lifelong learning as a sort of a policy. The Labour Party in the UK has now got policy around lifelong learning, so it's a policy issue as well as an institutional issue. And the other thing is, when we develop this model, we put lifelong learning in the middle, and it's not a hub. It's not a pivot, because hub and pivot have got connotations of power. Who's in the centre? Who's holding that? It's about a fulcrum. And if you imagine if you go to the gym and you have to stand on those boards that you've got to balance on, it's actually you as an individual, your learning contract. It could be you as an institution. It could be you as a community. It could be you as an organization, because lifelong learning is a constant balance on that board. It's a fulcrum. And you've got to maintain that balance. And that balance will change. As you get weary, that fulcrum will change. And you've got to constantly, it's a process. So that's what I really wanted to leave you with in that short introduction. Really digesting what excellent overview that Ruth gave this morning, but starting with who I am and where do I lie and what are my social determinants. And as Carl said, looking at that lifelong learning commitment, not just the 2 weeks of walking out of here and you're just going to integrate something. No, what can I do? What's my lifelong commitment to mainstreaming the social determinants? Because I think, as you mentioned, it starts off with one person, Greta, standing outside her school, and you get a global movement. There is no reason why this meeting cannot catalyze a huge change in the States if we all take your example and pick up those posters and go down into town and say, we want change. Thank you very much.